When a premature baby or any sick baby is born, quick actions have to be taken to save their life and to minimize any negative outcomes. Learn all about what these actions are and the life-saving equipment used in this video. Hi there, my name is Iman, and on this channel I teach moms and their families all about their high-risk pregnancy and the NICU to decrease fear and increase confidence. When a premature baby or any sick baby is about to be born, the NICU team is in the room or in the OR, if you have a C-section, ready to grab the baby. Depending on how early the baby is born, there will be more people on the NICU team. Once the NICU team stabilizes the baby, either in the L&D room or in the OR, then the NICU team moves the baby to the NICU. Here's a tip. Moms, you can have a peek of your baby once they're in the Isolette before they leave to the NICU. So make sure you ask for this. Or if your baby is bigger and more stable, the NICU team might allow you to do quick skin to skin right before they take the baby to the NICU. At this point, your baby is leaving with the NICU team. So make sure you get your spouse, your partner, a family member, whoever is there with you to go with the NICU team to the NICU so they can get photos and wait for you. In the NICU, once the baby arrives, we work very fast and very efficient. Everybody knows their role and place. We work as a team to stabilize the baby really fast. So everything that I'm about to mention when it comes to NICU admission is done simultaneously, all at the same time, to get the baby stabilized faster. Firstly, when the baby first arrives to the NICU, they will be transferred into an Isolette. The Isolette is like a heated cocoon. It has heat, it has humidity. We can control all these buttons from the outside. We, the nurses and doctors, control the temperature, the humidity, everything on this Isolette to make sure our babies are comfortable and are growing well. The Isolette also acts like a protection for these small babies from the outside world. Then we weigh the baby. And at this point is when we encourage the father of the baby or the family member to take a photo of the weight of the baby to show the mom. Here's a picture of my son's first weight when he got into the NICU. My husband took this photo. Comment down below if your partner or a family member was able to take that first weight photo and how big was your baby. I would love to know. Then after the weight is taken, the leads are put on the baby, so the baby's connected to the monitor. The monitor monitors the heart rate, the breathing rate, and the oxygen of the baby. Then a temperature is taken at the same time. The temperature is taken via the armpit. During the admission process, babies, especially small babies, can get very cold because the Isolette is open, and this can cause added stress to our babies. Therefore, it's very, very important that we monitor their temperature throughout this whole process to make sure it's in the normal range. The auxiliary body temp that we like is usually between 36.5 to 37.5. So the next thing that is done, and this is done at the same time of everything that I just mentioned, is stabilizing their breathing. So this is the main job of the respiratory therapist, the RT. We help the RT position the baby's head if they're intubated, or we help put on any extra breathing machine that the baby might need. For example, like a CPAP machine or nasal prongs. The common breathing equipments that are used in the NICU are ventilators, meaning the baby has a breathing tube, CPAP, nasal prongs, or the baby is breathing room air, which means they're breathing on their own. Then after, we do a quick lesson of the lungs and the heart, and we also try to get one blood pressure. And then either one of the doctors or one of our neonatal transport nurses will come in and put in an IV. The IV can either be a central line or a peripheral IV. So usually we give central lines to babies that are born less than 32 weeks. And we give peripheral lines, which is usually in the arms or leg, or even in the scalp, to babies that are older than 32 weeks. But this is different for every hospital. So just double check with your hospital. Then we pull lab work, either from the IV or we do a heel poke. Then they are connected to a TPN and we give protein and fats through the IV for extra nutrition. Also, antibiotics might be started on some babies at this point. Then a feeding tube is inserted. Either the feeding tube can be inserted through the mouth or through the nose. Through the mouth is called an OG, and through the nose is called an NG. Deciding on what type of feeding tube the baby might get usually depends on the type of breathing support they have. So usually babies that are intubated or have CPAP usually have an OG. And usually babies that come to us and just have nasal prongs on or are just breathing on their own, which is room air, they usually have an NG. And this differs from every hospital as well. So the feeding tube is how the baby would be fed breast milk or formula for the first couple of days, 2 weeks, until they learn how to suck and eat by mouth. And then a quick X-ray is usually done to check the positioning of the breathing tube, if they have one, and the positioning of the feeding tube. And also, of course, to look at other organs such as the lungs, the stomach, everything that the doctor needs to know at that point. Then us nurses do the correct positioning of the baby for proper developmental growth, and then it's hands off. So once the baby is stabilized after the admission process, we try to minimize handling. We only try to go in for assessments or feeding. Otherwise, we try to minimize handling the first couple of days the baby is born, especially when the baby is born really premature, which is less than 32 weeks. These babies are very, very sensitive, so any extra handling that is not needed can cause extra stress on them, which they don't need. Even older babies, which are babies born after 32 weeks, need to have that hands off as well, just to minimize stress and to help them transition. For babies under 32 weeks, the first 72 hours is the critical window. In this window, we try our best to minimize any unnecessary interventions that we don't need to do. Based on your hospital, you might be able to do skin to skin even if the baby is in this critical window. So just double check with your healthcare team on what their policy is. This is because the first 72 hours, which is the first 3 days, is a critical window to decrease the chance of an IVH from occurring. IVH, which is intraventricular hemorrhage, is also known as a brain bleed. Your baby's healthcare team in the NICU knows all about IVH. They know exactly what it is and what we need to do, what they need to do to minimize the chance of it happening. So don't worry, your baby is in the best hands and the best care. Therefore, this is a big disclaimer. Moms and dads, the NICU team can do everything perfectly when it comes to the admission process, but your baby might still get a brain bleed. And this is because of not what the team did wrong, it's because the nature of the premature baby's brain, how sensitive the blood vessels are in the brain and how easily they can burst. After the 72-hour window, a cranial ultrasound is done usually around day 5 to day 7 to see if there's an IVH or any other abnormalities of the brain. Everything that is done in the NICU is to always increase the positive outcome and to decrease as much as we can the negative outcome or the adverse effects of being born premature. Based on how sick your baby is, will determine if they need to be treated at a specific NICU level of care. Check out this video on which NICU level of care will fit your baby.